Good morning, everybody. I'm here doing a little lecture on hemodynamics utilizing the Acumen's parameters and using our Alta monitors. These are some new parameters, but kind of the same concepts based around hemodynamics. So let's get started. Okay, in hemodynamics, we know that there are three treatments, meaning that we assess preload, afterload, and contractility in our patients. So, afterload and contractility is actually very simple, right? It's just preload is, do we have volume coming into the ventricle so that when it relaxes, it can properly fill. Afterload is kind of the resistance that we are pushing back against when we pump blood out. And contractility tells us about the function of the myocardium itself and its strength. We're going to start off by talking about preload because I've always kind of thought of it as if we can't deliver the blood to the heart, we can't really expect the heart to do anything with it. So the first step is always making sure we have volume getting to the heart. Within preload, there's a well-known law, the Frank-Starling law. It has a graph that looks like this, and it looks at stroke volume and its relationship to preload. Right? So what that means is that, as we add volume to the system, right, our stroke volume should increase, right? But it's only to a point. The ventricle is only so big. And so another very important aspect of the Frank-Starling curve is that not only is there volume in the ventricle to move out, but the amount of volume in your ventricle really affects the strength of contraction, because just like any other part of your body, you have a natural range of motion with your heart. So when it's properly filled, it grips the blood, it moves the way that it's supposed to, and it's happy. When we're empty, we have a weak contraction because we're not moving in that natural range of motion. And when we're overfilled, the same kind of thing. We get overfilled and we don't have as effective a contraction. So again, down here, we have a weak contraction due to being underfilled, and up here, we've got too much volume on board, and again, we have a weak contraction. This point right here before the plateau is called euvolemia, and it's kind of like the perfect volume spot for your patient. And it's a target, but it's a target that can be kind of hard to hit because there's a lot of factors going into it. But let's take a person who's euvolemic and let's look at their volume status and how we lose volume. Maybe that can give us some insight into how to give that volume back. So if we start with a full heart, right? Like I said, we have a nice strong contraction, right? We have volume on board to move out, right? We should have a nice open vascular pathway, right? And that is the perfect scenario to move blood. And so we're able to move blood really well. We get good blood pressure, our nice robust arterial waveform. And so let's say we have a 120/60 BP, right? What our monitoring does is it looks at this area, right? Gives us an idea of how much volume moved during the contraction, and that gives us a stroke volume. So let's say our stroke volume here is 80, right? So that's a perfect situation for this patient. All right, so as we start to lose volume, blood pressure will drop at some point, but if you look at like the American Heart Association says that you can lose up to 30% of your total blood volume without significant systolic blood pressure changes. Now that would be for like a younger, healthier person. They would have more ability to compensate. But the idea is that there's a gray zone where you can lose volume and not have a change in pressure. So let's look at that. So we have less volume in the ventricle. Right? So our strength of contraction has weakened, right? Less volume to move. And so our body needs to compensate for that. And we're going to compensate in a couple of ways. So we need to keep our cardiac output up, right? And so cardiac output equals heart rate times stroke volume. So if our stroke volume decreases, typically, if our body's compensating normally, the heart rate will increase to balance out this cardiac output. The other big thing that our body does is we have systemic vasoconstriction. And so by narrowing these arteries, we're able to preserve the blood flow. And so what we'll end up with is you'll see about the same like amplitude or same pressure, but a much narrower arterial waveform complex. And so the blood pressure has maintained, but stroke volume has decreased down to 60. We have a decrease in our preload, weakening our pump, and an increase in afterload, which makes it a little bit harder to pump blood out of those narrow vessels, okay? So this is compensation, right? And if left untreated, at some point this person will decompensate. So let's look at that. All right, so we have now a very empty ventricle. We have still narrow vessels, right? And we've lost our pressure. Stroke volume will continue to have dropped, so stroke volume is now at 50. And the issue is just now that the ventricle is so weak that we're not able to generate enough force to keep the pressure up anymore. And so this is useful and kind of interesting, but really not super helpful yet. And so the question I ask, especially to my ICU group, is how many of our patients stay here and stay euvolemic for their entire stay? And the answer is probably 0%. A lot of patients get to a place where their volume status requires us, where they decompensate and requires us to treat. And so one of the things that can happen is, let's say we have this person who is now decompensated, they've got a low blood pressure, and we want to treat that with fluid. Well, how much fluid do we give them to get them from decompensated to euvolemia? Well, that's also a kind of a trick question because every patient's going to be different. So let's say that we give this patient a bolus of 500 cc's of fluid and we get them to like right here. Well, if we've gotten to a place where our blood pressure will increase, right? But we haven't really gotten them to a great volume status. What that means is that they will decompensate more quickly. So if you're the nurse at the bedside and you take this patient, you give them the volume, you go and take care of your other patient, and then come back and it seems like we're right in the same spot. Well, now we've had this transient response to volume, and it makes it really unclear for the bedside nurse as to whether what we're doing is actually getting us the result that we want. So if we have a vasopressor and our goal is to keep our blood pressure up, it can be very easy at this point to start a vasopressor. So let's say that we start or increase our pressure on this patient. Now remember, our issue is that we don't have enough volume in the ventricle. So so by artificially pressing these vessels and narrowing them even more, we typically will get the blood pressure that we want. It'll come up, but we will lose stroke volume. And so that's something that's really important to watch. If we're watching for our stroke volume when we add a pressor, if we have an incredibly significant decrease in that stroke volume, we should at least assess our volume status because it's quite possible that we're working out of order. All right, so that's kind of an overview of preload, and part of the reason that we watch stroke volume so closely is because stroke volume, while blood pressure and cardiac output have mechanisms for being able to compensate, whereas like we said, we increase our heart rate for cardiac output and we increase vascular tone for our blood pressure, the stroke volume is kind of a more pure volume indicator. So by watching it, we can get an earlier indication that things are changing. Another way that we can assess someone's volume status is by looking at their stroke volume variation. Now, stroke volume variation is a very sensitive number, right? So normal stroke volume variation is less than 10 to 15%, right? And as a patient gets higher and higher, it can be an indication that they will respond well to fluid. Let's talk a little bit about the physiology. So what we're looking at is when the arterial line kind of does this. And it comes down and goes back up. And this would be in correlation to their respiratory pattern. So this would be when the patient's breath was out. This would be when the patient's breath was in. And let me clarify that you typically only use this on patients who are intubated. So we have our patient's neck and chest here. We have our ET tube, right? It's important to remember that our mode of ventilation is different. We're pushing air into the chest rather than drawing it in like we normally do, and that causes a positive pressure change in the chest, and that affects how the blood flows through the heart and great vessels. So we have SVC, IVC, right atrium, right ventricle, left atrium, left ventricle, and aorta, right? So we have normal flow through the heart, the breath is out, we push that breath into the chest, and a few things happen. We get compression of the SVC, compression of the IVC. What that does is reduces the flow into the right side of the heart, which causes underfilling of the ventricle, or weakens that right ventricle. At the same time, the pulmonary artery gets compressed, right? Narrowing the outflow tract from the right ventricle, and so we increase the afterload on the right side of the heart while we're decreasing the preload. And so again, we're in a situation where we're asking like a weaker pump to work a little harder. And what happens is we lose some of the stroke volume during that time that breath is in. And stroke volume variation is normal for every person. Anyone who's breathing has it. It's just the higher that percentage is, the more likely your patient will respond to fluid. So if this stroke volume was 100 and this was 80, we would have a 20% stroke volume variation, which is high and could be an indication that your patient needs fluid. The reason that I'm saying could is because I said earlier that it's such a sensitive indicator. That's kind of the blessing and the curse. It's a blessing because it shows us this very kind of small change. The problem with it, or the curse portion, is that a lot of things affect it. So things that drive your SVV up that are not fluid are things like a increased PEEP, like a big pneumo, right? If you had PE, cardiac tamponade, right? These are all pretty big physiologic things, but the biggest one that we see is coughing. Coughing or fighting with the vent, those things really increase thoracic pressure. So just remember, anytime you increase your thoracic pressure, you are going to see more stroke volume variation. Like in the operating room, we look at prone cases just because of the compression of the thoracic cavity. And then there are two other ones that don't have to do with thoracic pressure. One is AFib, right? And I'll talk a little bit more about that one. And the other one is right heart failure, right? And it has to be pretty substantial right heart failure. And the idea behind that is just, like I was saying here, when we underfill the ventricle, it becomes very weak. And when this increase in afterload occurs, that kind of does two things that make it harder to move the volume through. But if this ventricle's dilated and so weak because we're in really bad right heart failure, this change in afterload is going to drive that SVV up regardless of the volume status. So it's something to be aware of. With AFib, this is one of the big misconceptions about FlowTrack and about Acumen are that if your patient is in AFib, you cannot use these monitors. Well, so AFib really drastically affects stroke volume variation, but doesn't have a whole lot of effect on the other parameters that we use. And let me explain why. So, if this is our EKG, and we have kind of AFib, we've got very irregular rhythm, right? And then we have our art line tracing. Well, let's say that we had good filling time here, but then this beat comes really quickly, and then we have a good amount of filling time, then another beat comes quickly, a good amount, and then kind of an adequate amount. Because of the irregularity in our R to R, we have changes in our filling time. And so inherently, we have a lot of variation in our stroke volume from one beat to the next. It just doesn't have anything to do with our volume status. And so in AFib, we really don't want to use SVV. That's the one thing that really takes it completely off the board. But like I said, it's also a kind of a confusing number and can lead us down the wrong path if we don't understand the physiology behind it. So it's something to be careful about. With our newest technology, the Acumen sensor, we now have we have a new parameter that helps us kind of clear up the SVV dilemma of whether or not we're looking at something that's a volume issue or not. Let me explain the DPDT really quickly. So DPDT is going to be a contractility indicator. It's change in pressure over change in time. And so it looks like this. DPDT, right? And so what we're looking at with DPDT, our normal values are anywhere from 400 to 1400, right? And what it's looking at is like the angle of the arterial upstroke. So let's say we have like that, and let's say our number is, because of this wide range, we want to make sure that we trend it for our patient. This is a very big difference from 400 to 1400. So let's say your patient had a DPDT of 800 and it's our first measurement. We don't really know where they should normally fall on this, so we really trend this number. Let's say we have a cardiac patient coming out of the operating room and we're resuscitating them, and let's say that they're on a tiny bit of epinephrine or some other inotrope coming out of the operating room. And let's say that our DPDT is, 900, and we're pretty happy with that, right? Remember, what we're looking at is this angle here, right? Well, after we warm the patient up and we resuscitate their volume status and things like that, let's say 4 hours later, this patient has really improved, right? And this angle is now steeper, and let's say it's, we'll make it 1600, right? Well, if this person was still on a little bit of epi, it could be possible that this would be an indicator that we could start weaning the epi. So it's an idea of how strong the heart is contracting, right? So the reason that I'm mentioning this right after I talk about the stroke volume variation is we all know that what I said at the very beginning of this lecture is one of the biggest things to affect our contractility status is our volume status. So when we have an empty ventricle, we have a very weak contraction. So that being said, when I pair my stroke volume variation, right, with my DPDT, right, and I'm watching this trend, as I watch my stroke volume variation climb, this can be an indicator that my patient has low fluid status, right? Well, if that's the case and I don't have enough volume or filling pressure, then what's going to happen is I'll see the DPDT trend down as well. So now I have an indicator saying I've lost contractile strength. I also have an indicator saying I probably don't have enough volume on board. And so these two things together really kind of give us a great picture and tell us that fluid is the issue. And that's kind of where we should be looking at. And so that's kind of how I pair the contractility indicator along with the preload indicator to really clear things up. All right, so we've determined that the patient could use fluid, but we don't really know how much fluid to give the patient. So one of the most useful strategies that I have found with this technology is the ability to give small boluses to assess the effectiveness of those boluses. So the idea is, instead of giving a whole liter, you give 250 cc's, kind of as a test to make sure that volume is going to help the patient. We want to give this volume quickly, right? And the effect that we're looking for is a stroke volume increase of 10% or more, right? And so the idea is this: if this is the right side of the heart, we've got the SVC and the IVC, we've got right atrium, right ventricle, pulmonary artery, left atrium, left ventricle, aorta, again, right? We are assuming that preload is down and that adding volume will help this heart beat more effectively. So we give the volume quickly so we can assess that right now. The volume comes in, right? The right side either stretches and accepts that volume or it doesn't. And the same thing happens on the left side. We'll go through the pulmonary bed, and then the left side either stretches or it does not. If both sides have been able to accept this extra volume, we'll pump it out into the arterial system where we're measuring for the stroke volume increase of either 10% or we get a yes or no answer, right? So we've taken this little bolus of fluid and we've assessed, okay, can this patient move this volume forward? We gave the volume in the venous system, and then we look on the other side of the heart to see if it comes out. If it comes out, then we know that we're helping with the effectiveness of each beat. And so if we were watching this on a Starling curve, let's say we start with someone with a stroke volume of 50 and we give a bolus and we go up to 60. Well, that would be more than 10%. We'd be excited about that. We give another bolus. You go up to 80. Okay, still having a good response. Well, if you give one more bolus and we go to 81, this is really the whole key, is I've found that now I'm falling off the curve. And so giving more fluid at this moment is not gonna help my patient. So this is a really great safety mechanism to help us prevent fluid overload in our patients. It also helps us to extend the usefulness of each bolus. So if I have a, say, 2-hour block of time, right? Let's say this is the 1 hour mark, and I get an order for 1 liter of fluid. Well, in this scenario, the patient really only used 750 of the volume right up front. So if I just gave the whole liter, it's possible that I'm like mildly overloading the patient during this period, right? Now, I don't think this is really going to be a huge hurt to the patient, but that volume is not going to be able to stick around in the vessels. It's going to have to find somewhere to go. Well, whereas if I built that patient up kind of more slowly and more intentionally, right, I would find out earlier, hey, you know what, let's pause on this volume, right? And then what I'm able to do is save a portion of that bolus for later. And so now, if I start to be unstable down the road at the 2-hour mark, in this upper scenario, I have to get more fluid ordered, right, to give that patient. Whereas if I was watching a little closer, I would still have this 250 to give it later. And so I've extended the usefulness of this 1 liter of fluid so that we get the most benefit from it, if that makes sense. All right, next so we've talked a lot about preload, a little bit about contractility. I'm going to go over the afterload parameters that we utilize. SVR being the one that's most well understood. So SVR stands for systemic vascular resistance. Right? Systemic vascular resistance, or SVR, is a calculation. It is MAP minus central venous pressure divided by cardiac output multiplied by 80. All right? And what this equation tells us, or what this calculation tells us, is it gives us some insight into resistance through the system, and it's concerned with like overall vasodilation and vasoconstriction of the vessels. And what we're looking at is a ratio of blood pressure to blood flow, which is how we find resistance in any system. So when we are looking at a low SVR number, we're typically thinking about vasodilatory shock, and when that number is really high, we're typically looking at more cardiogenic or hypovolemic shock. So SVR is one of those numbers where you can have someone that's totally healthy and has a kind of an abnormal SVR, and you can have someone who's really sick that has a normal SVR. So the way that I have used SVR in my practice is to help me delineate shock states. So if I have somebody who looks like they are in shock or going to be in shock, I can use SVR to kind of quickly assess what type of shock that is. So let me explain that. So let's say that I have an SVR of 400. Well, I know that this low resistance state means a couple of things, that I'm moving a decent amount of blood, and most likely I'm moving that blood at low pressure. So we can infer a couple things. Typically, the heart is working at least pretty well, right? It doesn't have to be doing great, but it's doing okay, right? We got volume to move, right? Heart works. And so where the typical thing that we see is that we'll see this low SVR in septic patients. The issue is we have this massive vasodilation, which decreases our afterload and actually makes the heart pump more volume through it. So we get a ton of flow coming through these really wide open vessels, right? And it's that high flow, low pressure drives this whole equation down and gives us a low SVR. So to kind of recap, if you have a patient going into shock or looking shocky and you have a very low SVR, your first thought should be vasodilatory shock and most likely an infective process like a septic type shock. On the other side of that, if we have a high SVR in a person going to shock, let's say it's 1800. Well, I can also infer from this that most likely the ventricle is not doing what it's supposed to do. The heart is failing, for lack of a better term, right? And because this pump isn't working, right? The body has to compensate by vasoconstricting again, which is great for our pressure, right? And great for keeping us alive, but it makes it hard. It's harder to pump that blood through this narrow system, right? So even though we may have a low pressure, right? That very low cardiac output drives that equation way up and gives us a high number. Now, the reason that I say that you're going to be thinking about either cardiogenic shock or hypovolemic shock is because hypovolemic shock is really kind of just the easiest form of cardiogenic shock to fix. Our heart is the problem, and hypovolemic shock is just very easy to add some volume to it and make it pump. They are like noticed the same way, if that makes sense, or they look the same. And so whenever we have a high number, think pump problem. Whenever we have a low problem, think vasodilatory problem, and that's kind of how I use it. So, and that's about what I got for SVR. So, and well, as I was saying, with SVR, we're kind of more concerned with, like vasodilation, vasoconstriction. Our other last parameter that we're going to talk about is another afterload parameter, and it is called EA-dyne. Right? The way that we find EA-dyne is pulse pressure variation to stroke volume variation, right? Again, pressure divided by flow to look at kind of a resistance type number. But what this relationship tells us about is kind of what happens when the volume comes out of the heart and enters the vessels. How do they respond, right? Do they stretch a little bit and snap back? Do they stretch forever? Do they not budge out of the way? All of those things are going to help give us insight into what to do for our patient next. So let's look at that, right? Let's say that we have the same heartbeat going into 3 different vascular beds. Let's say we have a normal vessel, right? What we end up with is kind of a normal looking arterial tracing, and our ratio of PPV to SVV is roughly 1 to 1, right? So our normal value is from 0.9 to 1.1, right? Okay, so when we have very, very floppy vessels, right? The vessel, it stretches and stretches and stretches, but it doesn't have that elastic ability to snap back. Well, what happens is the volume comes into that vessel, the pressure starts to rise up, but some of the pressure gets dissipated into the vessel wall, and because there's no tone there, our arterial tracing would look different. It would have that rounded kind of shocky look. Right? And so this top portion of the pressure is being lost into the vessel wall. So what that does is it drives down the PPV. The SVV remains around the same. And so we get is a less than or equal to 0.8 value. And I'll talk about what we do with that value in just a minute. On the other side of this, if we are very rigid, right, the vessel doesn't budge, well, when that volume comes into the vessel, right, since the vessel doesn't move out of the way, we get a little added bit of pressure at the top. Right? We get this little bit of pressure. That, in turn, drives that pressure. The pulse pressure variation up a little bit, stroke volume variation stays around the same. We get an increase, or we get a greater than or equal to 1.2. All right, so now we have the values and the normal values, and hopefully the concept of how this thing works. So the way that you can use this number is, let's say that you have a patient and they are in front of you and they have a lacking blood pressure. Let's say it's at 55, MAP of 55. And we know that we want to keep that blood pressure up at least a MAP of 65. If we have a patient with a very, very low EA-dyne, let's say it's 0.3, right? Well, that tells me that we've got this public shopping bag vessel that will just stretch forever. And so even if I can increase forward flow through these vessels, I probably will not get an increase in my blood pressure. So if I have a very low EA dyne and I'm concerned with blood pressure, I should probably consider vasopressors first. That's kind of the best way to explain it. Whereas on the other side of it, if I had a 1.3, then it might make more sense to just give some fluid or maybe help to get volume moving through this person, and that in turn will help bring up that blood pressure. Okay, these are all of the values that we decided to talk about during this. I hope that this was helpful. Please give me a call anytime, and I'd be happy to help you out with these numbers. Have a good day.